Hi, everyone. I'd really like to welcome you to NEDAcon Spring 2021 panel on treatment access in 2021. I'm Tamara Pryor, a NEDA Board Member, and I'm really excited to present this panel today. With very different treatment teams, we will discuss how they've shifted their methods and priorities during the changing landscape, the very changing landscape of the last year and 3 months. NEDA is hosting this discussion as an opportunity to share some of the changes in treatment space over the last year, but we're not recommending or endorsing any of these specific programs by inviting them to be involved. If you or a loved one are looking for treatment options for an eating disorder, we recommend you to contact the NEDA hotline to discuss what treatment options may be best for you and your situation at www.nationaleatingdisorders.org/helpline. So I'd like to get started by just introducing our panelists today and telling you a little bit about them. First of all is Kristen Ulrich. She was the site director at the Renfrew Center of Boston. She received her bachelor's degree from Westfield State College and her master's degree in social work from Boston College School of Social Work. Prior to joining Renfrew, Ms. Ulrich served as the director of an outpatient mental health clinic in the greater Boston area. She has worked in a variety of settings with different patient populations, including patients with comorbid trauma, histories, depression, anxiety, and self-injurious behaviors. Ms. Ulrich is a member of the National Association of Social Workers, Massachusetts chapter. Dr. Deborah Michel is the regional clinical director of Eating Recovery Center in Texas. She is a licensed clinical psychologist with over 25 years of experience in the treatment of eating disorders and related conditions, including body image disturbance, as well as mood and anxiety disorders. She is a certified eating disorder specialist supervisor, which is a certification status granted by the International Association of Eating Disorder Professionals, IADAP, to healthcare professionals who demonstrate clinical expertise in eating disorders through education, experience, and examination. She's been involved in prevention, education, and advocacy efforts on behalf of sufferers and their loved ones throughout her career. Dr. Cara Bohon is the VP of Clinical Programs at EQUIP. She's a clinical psychologist with over 15 years experience in eating disorders. She was awarded an Early Career Investigator Award from the Academy of Eating Disorders. Congratulations. And her research is funded by NIMH and published in top-tier journals. Prior to EQUIP, she was faculty at Stanford University. So thank you all for being a part of this conversation. I have wanted so much to be involved in a conversation like this with various people from our field for the last 6-8 months in terms of not being able to go to conferences and talk to people in terms of what's working, what isn't working, how's it working, how are you holding up, what are you experiencing in terms of how our patients are struggling in the same way and yet in very different ways through this experience. So I think I'd like to start with taking each one of you and giving you each an opportunity to talk about your programs and kind of what type of treatment you are providing currently for your community. So if we could start with Kristen.
Renfrew, we're back in March 2020. It feels like so long ago, right? It feels like that whole month was a blur. Renfrew as a whole switched to running their outpatient programs to a virtual platform. So, Renfrew continues to have its 2 residential programs in Philadelphia and Coconut Creek, Florida, that are in person. And then there's 19 non-residential sites across the country that have fully transitioned to virtual programming. When I say fully, it was more than a year ago, right? So we've been operating as a virtual program for over a year. And so we're running our partial hospitalization program Monday through Friday virtual. We're running our intensive outpatient program 3 evenings a week. The nights vary for different sites that our patients attend. And it really mirrors our in-person programming. Renfrew did they took a huge undertowing and an initiative to really mirror our in-person program to our virtual programming. So patients are getting supported meals, they're getting individual sessions, psychiatry sessions, they're getting groups, the same as they would as if they were in person walking in the building. So they're still able to establish that connection with the staff to help them through the treatment process, which is really important. There's a lot of staff behind the scenes doing a lot of work in the virtual programming. So we're using breakout rooms for that one-on-one connection between patient and staff. We're using breakout rooms with patients in groups and in meals to really provide that individualized level of care in this virtual landscape. Yeah.
Deborah,
Yes.
describe yours.
Yeah, so currently, very similarly to Renfrew, we had additional services that went virtual as the pandemic hit, to be able to meet the needs of those with whom we serve. Currently, we have, for some time, we kept our IOP on, our partial hospitalization on site. So we do have on-site care for our partial hospitalization folks. Of course, res and IP remained on site always. And for our intensive outpatient program, we currently have virtual services that we offer for them. And I really want to emphasize the undertaking that Kristen mentioned about what it takes to really mimic and really provide the same high quality bar of care in the virtual world that is given on site. So again, we have a dedicated staff that is virtual only. All of our family offerings that we would offer on site, those are offered to all of our virtual patients. We're presently beginning to take a look at our transition to intensive outpatient services back on site, in addition to keeping virtual services for our intensive outpatient program. So years ago, we've had IOP, virtual IOP for about 5 years now. And certainly with what occurred with the pandemic, it was a massive undertaking to then change the scale. So flipping so many of our patients, because our medical leadership decided that the relative risk for those at IOP level of care would be less, and they could remain in virtual if they were medically, psychologically stable enough to do so. And if not, then they would need to come on site to PHP. So we have, as part of making that determination, we have certain guidelines, if you will, of what would be appropriate for virtual care versus, what is necessary on site. And not unusual that we, get folks in virtual. It's kind of a foot in the door, and sometimes we find out that they really need to be able to come back on site. But it's certainly telebehavioral health has changed the landscape of everything. And gosh, I would have never guessed when I first started back in the 90s, the early 90s, that we would be here. I think it's very exciting. I won't jump ahead. I'm sure Tamara's got other things she's going to mention about this, but I think the potential and the people that we can reach are going to be amazing. We've already done it.
Dr. Bohon.
Yeah, so I will jump in that we had Equip in a little bit of a different situation in that we didn't pivot when the pandemic started, for 2 reasons. One is that we weren't taking patients yet when the pandemic started. So Equip really just started seeing patients in the fall of 2020. But actually, the other thing is that Equip was virtual from the beginning. The goal of Equip was always to increase access to care in geographic ways. So realizing that a lot of people were traveling to get expert eating disorder treatment, and that travel was to their detriment, right? So they weren't necessarily recovering in their home environment. There's that transition back home from treatment, and wanting to kind of ease that as best we can so that people who are maybe in rural communities or just in places where there's just not expertise that could still have access to care. And so Equip was actually always going to be virtual. And so the pandemic if nothing else, it almost sort of normalized what we were already planning to do, and increased, I think, the acceptability. I will say when Equip started, even our founders would have said, if you can get in-person treatment, do it. If you can't, then we're here. And I'll say we're learning that it's way more effective than we realized that it could be. You know, our primary model of care is family-based treatment. We're treating primary adolescents and young adults who have family that can support them through recovery. Family-based treatment, which I used to do in brick and mortar treatment centers at Stanford for quite a while. We would have, like, for example, a family meal. The family would come and bring a meal into our office, and we would support them in how to help their child get through the meal, eat the appropriate amount of food that they needed for recovery, things like that. But it was a little bit different from normal because they were in our place, in our office, right? Now we do a meal session with a family virtually. We get to see what meals look like in their actual home at their kitchen table. We get to see, oh my gosh, the dog is the culprit in, like, getting, you know, the food is slipping out to the dog. That would never have happened in our office. And so we actually get kind of a nice picture and a nice window into what's happening at home that we actually didn't get when we were seeing them in our office. So there's been a lot of kind of perks, I would say, that I hadn't even really fully anticipated. But the biggest win, you know, as we started, the reason we started Equip was really to improve access and have people be able to access treatment without leaving their homes. And that's kind of fit into the pandemic situation.
At EDCare, we did not go virtual with our PhD except for 2 weeks. One of those quick pivots, we were a hotspot on Thursday and we went virtual on Friday. We did take our IOPs virtual for approximately 3 months, and now everything's back in-house. What was interesting, and the reason I'm kind of mentioning that, is that we decided to do some pre-post questionnaires in terms of people's preferences, pros and cons, what they liked, what they didn't like. And in all of our adult programs, the results were that they'd prefer to be in-house and did not feel the same connection with their peers, certainly greater isolation outside of program, difficult to sit on Zoom for 8 to 10 hours a day. We shortened the program to 8 hours from 10, just kind of being in front of Zoom for that long. But the positive feedback that we received for the virtual program was from the adolescent program. For the very reasons that you mentioned. Well, one is the parents didn't have to drive. So that was like the number one, it was transportation to and from the center. But the other was just the feeling that we were seeing things we could have never seen or known, to get a fuller picture of how the family worked together. And like you say, you know, if the dog was getting fed under the table, or if we had to tell the adolescent to please sit up in their bed, and all of the things that we learned really that were so critical about the family. So we had a very different experience with our adults than we did with our adolescents, and wonder if we could just kind of move into that in terms of pros and cons, because it sounds like we've all done this to varying degrees with varying degrees of success.
The access to care has definitely been one of the biggest pros that we've seen in at Renfrew. You know, specifically to Massachusetts, where, you know, we're located in Boston, and then we have remote parts of the state, right, where they don't have access to care. So those patients have been able to join virtual programming where it would have taken them 3 or 4 hours to get to Boston every day, and it wouldn't be feasible for them. So definitely the access to care. We're able to meet the patients in their home, right? The adolescents, parents don't have to drive them. You know, with the pandemic, a lot of our patients, adults and adolescents, had multiple responsibilities with the added stress of the pandemic that would have prohibited them from entering into treatment. So, you know, whether it had been their they were working from home. Their kids all of a sudden were home, right? One day, and they need to figure that out to do remote schooling plus work plus want to come into treatment. So, being virtual really helped a lot of patients come into treatment who, if we were in person, wouldn't have been able to access care just because of the overall stress of the pandemic. We're also able to access patients whose maybe have prior medical conditions that would put them at risk for going out into the community and maybe taking public transportation or having to be out in the community per se. So those patients were able to enter treatment that if we were still in person would have felt uncomfortable coming into treatment. I think it's definitely given us a glimpse into families. We've done a lot more family work because everyone's been home. Working remote, and even we were doing Zoom like family sessions, but since the pandemic, that's been the only thing we have been doing. So family involvement has really increased for our adolescents and our adults. They're able to bring supports to program that they might not have been able to bring before. Mom and dad are working in the same house, or their guardians are working in the same house, and they're both jumping on Zoom to join a family meeting. So that's definitely been a pro. One of the things I think just in the virtual landscape that I bet every single one of us on this panel has seen is just an increase in the amount of individuals reaching out for access. I think that is a con of the pandemic, and that a lot more people are just isolated, and mental health concerns have just risen over the past year and a couple of months since the start of the pandemic. So I do think that we've definitely seen an increase. Specifically for us, we have seen an increase in adolescents coming into treatment since the start of the pandemic. We've seen patients who have never been in treatment before, and they're entering into a higher level of care since the start of the pandemic. So that's also a con and a pro, I would say, just because they're able to access care, but we have seen an increase in the number of individuals accessing service. I would say that a con of being in this virtual landscape is that not everyone has access to technology that you need. I think that can be an access difficulty for a lot more like rural populations that might not have great Wi-Fi, right? We've even seen it with some of our patients in program that their Wi-Fi might drop, right? And then we have to figure out, did their Wi-Fi drop? Did they leave program? What's going on? So I think, that's definitely has been difficult during the pandemic, and I think that you ideally need to have a private space, and not everyone has a private space, especially if you're sharing apartments, or you're sharing homes with people, you have kids coming, you have childcare at home that you have to focus on. That's definitely been, just a difficult area for a lot of our patients to navigate with just the way the pandemic is going. In Massachusetts, we are opening up more, which is great. So we've definitely seen some of those barriers disappear with our patient population.
So we, similarly to what Kristen is describing, certainly the access to care is certainly a very strong positive. And we have just seen, I know like the rest of you, unprecedented levels of people seeking care. The demand has just been astronomical. We know that majority of programs across the country have wait lists now. We've certainly seen the acuity go up quite a bit. The acuity has gone up quite a bit. Hence, when I was mentioning earlier, sometimes we have folks coming in that have met all the criteria for a certain level of care, and then we get to really be able to work with them, whether it's virtually or on site, and discover that they really need more support than what we're able to give at a lower level of care. So I do think that certainly the ability and acceptability that Cara mentioned earlier regarding virtual services, I've seen a tremendous positive change in that. Now, again, ERC published a study, their research team a while back, about the efficacy of virtual treatment, very well accepted. And I think that the pandemic really enabled us to flip that over to the mass scale to the masses, and maybe to like an older age group like myself that might find it, our younger ones, you know, are so much more comfortable oftentimes with technology. And even clinicians, right? I mean, I think at the very beginning, I don't know what you guys found, but I think when we said we really need to try to, you know, take care to people now, since not everybody can come on site, we need to deliver the care to where they are, take it to their home virtually. I think certainly we had plenty of clinicians, tech savvy, all of that. They're ready to jump on board. Let's do this. And then I think there were clinicians who felt like, oh, well, I know that we've published this study and it says it's, you know, it's efficacious and the outcomes are great, but what about, you know, they're really doing this on a larger scale. So I think you know, everybody has been able to see how potentially positive this could be. So as Cara mentioned, having the family meals, that's what we do. And I think is a super positive for our child and adolescent population, is that one of the requirements to be in our IOP is the parent has to be at the meal on camera for every meal that the child is in. So we're doing those family meals 3 times a week with them. And it's been, yes, you know, if the dog's under the table or there are people running in and out behind, you know, all kinds of things going on. When it came to PHP, much like what you found, Tamara, I do think, even though we also shortened our hours to try to make it more acceptable, that just because eating disorders takes such a long, comprehensive day, that it was difficult, you know, for people day in and day out to remain on camera. We certainly had people who did it and who also thought it was just fantastic and absolutely what they needed. And we did have others that said, you know, if they would have a choice, they would prefer to be on site. I mean, we're very glad now that, you know, all of our PHP is on site at this point in time. We don't have any virtual PHP on site, but it's IOP where I really think the potential to expand services. You know, Texas, I'm in Texas, is a huge state, many rural areas where, you know, even in the greater Houston area, the times that our IOP will occur is often conflicting with rush hour. So people can live in the greater Houston metroplex, but just you know, trying to physically get to a center, depending where they're coming from, can be very difficult. So I think it's been wonderful that we now have this, and will continue to have this virtual option to make sure that people are getting care one way or another. And that we also then have brick and mortar centers where if virtual isn't sufficient for what they need at a given point in time, we can then transfer them to, you know, a brick and mortar center.
Yeah, so I mean, I echo both what Kristen and Deborah have been talking about in terms of, obviously accessibility is probably the #1 pro. I'll add to that, especially working with families. You know, seeing families and doing family work in person often meant we'd get one parent. If we were lucky, we'd get both parents to show up. But often another parent was working or busy or, you know, something else, and that commute makes a big difference, right? Yes. So just driving to the office, even if they were fortunate enough to live within driving distance of eating disorder expertise, they still had to drive there from wherever, even if it's 30 minutes, 40 minutes, an hour. And taking that commute out means we have increased the participation of the whole family. And so we get parents logging in from lunch breaks at work. We get parents logging in from, you know, we had a family whose dad was a construction worker and able to log in on his phone from, you know, a lunch break on a construction site. And, you know, he wouldn't have been able to participate in treatment otherwise. And so even just the accessibility of the patient themselves, but also members of their family and their community who are important to include in treatment, get to be a part of treatment because it's virtual. And I had done that prior. I had tried to say, okay, I've got this portion of the family in my office and we'll have, you know, this parent call in or this parent even Zoom in, you know, or something. But to manage people physically here and online simultaneously, it's really hard to do kind of a hybrid session. But having everyone in that session online, it meant that everyone gets to be engaged at the same in the same, whoever is virtual before always got left out from the session, but having everyone virtual then means everyone gets to be a full participating member. And so I think that has been a benefit. So it's an aspect of accessibility, but even beyond just the patients themselves. I think just like what Kristen was saying, the accessibility piece for people whose connections and technology isn't as great is a challenge. We haven't had to do this yet, but we have talked about kind of sending out hotspots or things like that to people who might need them. And so hoping that can help. Like I said, we haven't tested that out yet. We haven't had to, fortunately, but that's sort of on our radar to think about other ways to improve that accessibility piece.
And the one for us that I think is impacting the staff with the stress that they've experienced themselves during the pandemic, and particularly our frontline staff being in-house and trying to make our environment as safe as possible. So a lot of anxiety that we're managing with staff, and then managing these wait lists. The patients that want brick and mortar being on a wait list is we have found that our admissions team are spending hours and hours calling people back who are getting increasingly feeling more desperate. Their symptoms are getting worse. Programs are full all over the country. And then when they do come in, our patients, I can't believe the level right now of, there's always a great deal of comorbidity, but the substance use, patients that have been home, and I'm in Colorado, so take that in consideration, but patients that used to be in program all day, and then maybe they'd go home and smoke cannabis at night and said it helped them sleep. But these are people that are smoking and using all day, every day. Alcohol and drugs. So when they come in, our staff are stressed and our patients are sicker. And we're trying to do all kinds of things for staff morale, but finding it very difficult to manage that. And just wondered if the rest of you have experienced that and how you're handling it.
The other benefit of virtual work is actually has been for us in hiring providers to meet the demand, because we don't have to hire within a radius of a particular physical location. We can hire providers actually who are wherever they happen to live. We have licensing requirements, obviously. So Equip operates in California, Texas, New York, and New Jersey. So if there's a license involved, someone needs to be licensed in one of those states. But other than that, the state of Texas is quite big, and we can hire anyone in Texas. Anyone who's licensed in Texas could work for us, no matter where in Texas they live. And so that has been really another benefit of the virtual space, is in hiring providers, and so we're not limited by that geography, which then helps us with the demand. And so instead of holding wait lists, we can just keep hiring and training and hiring and training and hiring and training, and making sure, obviously, we're doing quality assessment, making sure that our patients are doing well with the providers that we're hiring, but we don't have that geographic limitation, which is another benefit there. I will say the other thing that Equip does to try to address, Tamara, what you're talking about with regards to acuity, because absolutely 100%, I have seen the same thing that you're talking about, where the severity, the acuity has really seemed to increase. The stress of the pandemic, the isolation of the pandemic has really exacerbated a lot of eating disorder symptoms and their comorbidities. And the other thing that we do at Equip is a very team-based approach. And so each patient at Equip has a 5-person care team. And so hopefully one of the providers on the team is there to be able to kind of catch anything that's concerning, talk to each other. And then the other thing about that is also provide each other support on the team. So if someone had a really tough session with a patient who's really struggling and having a hard time, and we're worried about them, scared for them, they have the other members of their team, of that provider team, who knows that patient really well, to sort of say, hey, let's work together, let's brainstorm, how can we help this patient, and really use that camaraderie of the provider team to meet that severity and that acuity that we're seeing, because it's 100%. It's there. Yeah.
You just explained to me why we are having such difficulty hiring. Never had this much difficulty. Never.
My understanding is this is across the U.S. now.
Yeah.
That healthcare providers, or because of the pandemic and the acuity and the just mental health crisis, if you will, that we're seeing this across the board. I mean, I love what you brought up about the hiring to meet the demand, and we're interviewing several times a week on a steady basis now. And in terms of taking care of the staff, we have a culture committee, and of course, we used to have all these in-person gatherings together and things that we would do that really helped in terms of outside of the treatment teams and care team meetings to try to just again lift one another up and have an atmosphere of collegiality. And so we've had to adjust what that looks like because we couldn't be together in the same way. We're looking forward to doing that. We also have a virtual culture committee as well for the virtual team, the dedicated virtual team, so that they get together and have their own events and things, so that they don't feel isolated in their care teams, but we have everyone together and have all staff meetings to really try to support one another. Different, again, sort of moving toward technology, but all sorts of apps and, resources that can support clinicians. And so we've also, in addition to our family education events, which are all now virtual, and they have been for some time now. And we have around over 30 a month. We're doing virtual clinician support groups as well, because we're finding that because of everything that you all have already mentioned, our clinicians are at a place where they need a safe, open space, where they can go talk about how they're managing and really trying to make sure that staff, I'm constantly reminding them about our EAP resources and that it's confidential, that this is free of charge for you, because it's self-care is so important right now for all of us.
Yeah, so I can echo a lot of what Deborah and Cara have both said. We've definitely seen an increase in the acuity. Everyone that comes into PHP and IOP has a treatment team, so hopefully someone from that treatment team is able to catch before the acuity rises. In regards to staff morale, we have team meetings. So the staff have been coming into the office kind of like in a hybrid. So we've been staggered. So that's helped a lot with the staff morale, even though we're running virtual programming. I'm in the office today. There's a handful of us here. So at least we're able to see each other and have masked conversations, right, in the hallway. So that's been really helpful for the staff morale. Doing we do get-togethers on Zoom, right? Like we did a murder mystery event on Zoom, and it was great. It was so much fun. But so we try to do we're trying to do that stuff, and really, when I'm meeting with the staff in individual supervision, I have other staff who do supervise some of the direct staff as well, but really checking in with them on how they're doing with the pandemic. I think that is extremely important, and acknowledging that not only are their patients that they're treating experiencing the pandemic, they are experiencing the pandemic. And how is that affecting them from sitting across from someone who is struggling with the pandemic or struggling with isolation, not seeing friends, not seeing family members, and how that could be their life too right now. And really talking about those parallels in supervision and really provide the staff with outlets for that has been extremely important. Group supervisions, team meetings, we use an instant message chat through Microsoft Teams. So we're constantly talking to each other about patients and collaborating, even though we're not in person. So that's been really helpful, just from a perspective of, oh, this patient didn't show up for this group. Are they with someone in a session, or should I be calling them to worry about safety? That is something that we have seen across, I would say, most of our non-residential sites, is that there's been an increase in suicidal ideation for our patients. So we've had to really increase the staff awareness and increase staff training around that. for our patients coming into care. So that's been, yes, we've seen higher acuity with eating disorders, but we've also seen a substance abuse, suicidal ideation, just the comorbid diagnoses, we've seen an increase in that. So just really supporting the staff around how, yes, we hear you that the acuity is high, and really supporting them in supervision and, morale. I've sent like little gifts to the staff in the mail where they get something in snail mail, which no one gets that anymore, right? So they love that, or like a handwritten note or something to try to increase that personal connection with the staff. Especially, I did a lot of that early in the pandemic, just to, drop the staff a little note and send it in the mail. And it's nice because not a lot of people send that stuff anymore in the mail. So, yeah.
Yeah. Kristen, I like your talk about the Microsoft Teams use of that outside of communication, because one of the things that I have thought about is how can we recreate sort of the office hallway where, in real life care, if you're doing outpatient work, you can sort of like grab someone real quick and just be like, whoa, I just had a really tough session. Like, can we just like debrief about it? And so we've sort of had to create that space to say, hey, I just had a really tough session. Is someone around just to like debrief? And so we'll jump on a Zoom call and just like have that, it has to be a little bit more deliberate as opposed to something that just happens, but creating that space virtually for each other, so that even though you're might be working from home, seeing patients through your computer, that you still are part of a team and you have access to that team to help support you give good care. So. Yeah,
that's been really helpful for the staff, is just like messaging, right? And they'll message me and some of the other members of the management team, and then one of us will be like, okay, I'll jump on a call. I'll call you. When are you free? I'm free now. So it's really helping support the staff that you are still available for those conversations, even if it's not a hallway conversation, and then, or when they pop in your door and they're like, you have a minute? We know it's not really a minute, right? Those conversations we've really been able to replicate through like using different virtual platforms, which has been extremely helpful for the staff.
I so appreciate hearing that. I think that, here we are talking about, and have been talking about for 40 years, the disease of disconnect, in terms of working with eating disorders, and for us as professionals to recognize the need to still experience the connection with our colleagues and with one another's, and how to facilitate that with our staff. It's certainly been, it's really kind of come home to us in a way that we've always had to be aware of it, but to be more creative and to find other venues for being able to do that has been so absolutely important. Why does treatment remain so inaccessible to so many? I think programs like Equip and what you're doing are just phenomenal. And what we have all learned in terms of being able to now use this virtual world provide access to care. But there still seem to be barriers. And I know one of the barriers for our program is that we're the only Medicaid provider in Colorado. And now Medicaid, when they need a higher level of care, Colorado Medicaid will not pay for out-of-state inpatient residential, and that this is happening all over the country where these patients, they have nowhere to go for a higher level of care, and that Medicaid has put all of these restrictions. And these are patients that also have fewer resources, period. So for us, that is something that is a battle that I think we still have to fight in terms of access to care for people with fewer resources.
We just talked about the acuity rising, right? So it's the acuity rising, and I think that if they need a higher level of care, I think they can go to one place in the state of Massachusetts that always has a tremendous long wait list. So it's really hard to, not only is it I think the resources are limited, right? But then the resources that those patients have are even more limited because of the wait lists. So there's like two negatives already right there, and they're not even in the door yet into treatment. I do think that there is a stigma with, mental health and eating disorders coming into treatment that still exists. I think There's, you know, a lot of cultural stigma for a lot of populations of coming into eating disorder treatment and mental health treatment as a whole. I think that still exists. You know, I think there's a lot of there's weight stigma out there in relation to you know, if someone is in a larger body, am I sick enough to come into treatment? You know, we see that a lot. I think there was just an article recently of an actress who came out this weekend and I forget her name, I can't think of it off the top of my head, that just came out and talked about how she has not the atypical eating disorder diagnosis. I think that's still out there. And I also think it's shame. It's shame and embarrassment too of needing to come into treatment. I know, I think that as for society as a whole, there was a huge destigmatization for coming into treatment for other mental health disorders. And I feel like eating disorders, we still need that. We still need that advocacy to reduce that stigma for our patients to come into treatment with us.
In addition to the things that Kristen mentioned, certainly I've got concerns regarding the coverage that is in existence today for virtual services and where states and insurance companies are going with this in the future. We are strongly advocating on multiple levels to continue to get virtual benefits, if you will, added to insurance plans, because we have the evidence to show the efficacy. It provides much greater access to care for people who would not already have it. So definitely, I think being able to advocate for that is very important. In addition to taking a look at what are the other barriers, if it's technology, you know, what can programs do, as Cara mentioned, to help kind of mitigate that. If it's weight and vitals, we're looking at some options at ERC that we may be able to do for people who either don't live, you know, close to a medical center to go, or a medical office to get their weights and vitals. We know it's critical for their health. We follow that. They don't have a trusted family member perhaps, or who would be able to do that, and we don't want them to have a scale. So we're looking at some options that we could do to facilitate that. So I think just continuing to ask ourselves, you know, what are the barriers to care, making sure healthcare professionals are as aware as we are about the level of eating disorder acuity and the comorbidities, mental health in general, going up across the nation. And we're really trying to reach out to our healthcare providers in our communities to make sure they know, you know, there are places here people can get help. And that will, you know, again, kind of bring treatment to you virtually if they can't come on site. So I think all of us continuing to advocate in those ways is so important.
I obviously echo all of those statements. We've been working pretty hard to try to get contracts with lots of insurance companies. We're working on Medicaid at this time, although as you mentioned, Tamara, Medicaid is not just one thing. It is, you've got each state has its own, and then within a state you might have state approval, but then each county might operate independently, and then you've got Medicaid that's contracted through this corporate provider, or you've got this corporate provider who's operating the Medicaid in this state or this county, or, you know, and there's all these different aspects. It's like, okay, you've got the Medicaid approval, but then you still have to there's so many pieces of the puzzle that I think the general public isn't really aware of, that I wasn't necessarily even aware of until I started, you know, becoming involved in some of this. And so it's so much work that I think about the systemic barriers and how I would love for, like, you know, like government lobbying to just make this easier. It shouldn't be this hard to get contracts, you know, because that's what's actually going to help people get access to care, right? If it was easier to get contracts with Medicaid, we would provide care for them. You know, we would provide care for these people. We're working on it. We're trying really hard, but it's not one thing, it's so many different contracts that have to go into place to actually give people access. And so there's the financial barriers that I wish were easier. There's licensing barriers that, as we're trying to work on, having everyone in the US have access to virtual care, but each state has its own laws and rules, and you have to have, this state requires this and this state requires this, and they're all unique and different in their licensing requirements and operation requirements. And it's just this huge barrier. So we would love to, be able to help a patient in Wyoming, but the process of actually being able to treat a patient in Wyoming, even virtual, even though we have the virtual capabilities to do it, there's all these legal barriers. And so I would love, like advocacy and things to support at the government level to actually make it easier for treatment providers to provide care that people need to improve that access. And then getting into just systems and even people's awareness that they have something that can be treated, that there is treatment for it. Kristen, you mentioned cultural barriers. I think we know that there's a lot of medical racism at play, and people who are just as likely to get eating disorders, but because of the color of their skin, they are not being identified by people. They're getting brushed aside because of the size of their bodies. They're not getting identified. It's assumed that, this is something else, and you just need to lose weight and then you'll be fine. Well, actually, that's the problem. You're not listening. And feeling like we really need to help support at like the primary care doctor level and create education and advocacy about who's getting eating disorders, that everyone is getting eating disorders, and to really look for it everywhere so that people can know that there is help, there are options, and it's out there. So they feel like there's like so many different systems and levels and places that we need to go to actually improve. I would say the other thing that I'm excited about when I think about virtual care is the ability to provide people who are otherwise maybe don't fit the stereotype, who might go to a treatment center, and because of the numbers, predominantly might see people who don't look like them in the treatment center. The more virtual care options there are, the greater likelihood there could be of actually creating a group that is for, patients who are non-binary, so that they get a group that's actually for them, and they don't have to be the one person in their group with their gender identity or something like that, right? So I think that's another barrier that virtual care actually gets us to, where we can create a space. There might not be that many people in this geographic location, but maybe if we're doing virtual care, we can actually create that space where they don't have to feel alone in their identity and their treatment.
This is bringing us back to a little bit of our conversation, but it's definitely relevant. So we actually are utilizing shared resources for those groups right now at Renfrew. So we have breakout rooms within our PHP and IOPs. We have a SAGE group, which is sexual and gender equality, and it's run by also members of, so the group leaders are also members of the LGBTQA+ community as well. We have a BIPOC group that we run as well as a breakout group, and it's great because we're able to utilize our site's resources where we're virtual right now. So it's been really great just to have people that are struggling with similar issues, right, in the groups, and people that that represent your culture in groups with you as well. Has been a huge pro of the virtual landscape.
Yes, we've definitely seen the same thing. We're able to provide binge eating disorder treatment that is not, it's in a separate milieu, whether it's virtually or on site, so that there's no mixed milieu. So those that are in larger bodies are not feeling different from the rest of the group that's there. So we're very glad that we're able to offer that both virtually as well as on site. And so many have asked for that we always see these groups filling up and the separate programming altogether.
Where do you see the future of this as I listen to what the positives, I guess, of what have come out of a very, very difficult year? where's this going to take us as a field? I mean, I feel like as we go virtual, and you've just been describing the benefits of being able to offer select groups for people who may feel like they're this single person in a group where everybody else seems more similar than different. But do you see the field going into doing this more segregated treatment rather than integrative treatment, where the underlying issues with regards to the eating disorder, if you close your eyes, you wouldn't know what color the person was or what size they were? Are we going to segregate more in doing that? Or do you feel like there's just more benefit for people to first get that connection and feel like there's a place for them in treatment?
I think it's really about the connection piece, right? The connection of being able to form connections with others. I think that's been a huge, important key factor in virtual treatment that we've been able to successfully achieve. By utilizing all the virtual resources that we have, we've been able to, I would say, provide even more high quality care to our patients and have them establish connections with one another. I would say that I think you're going to see a lot of programs have maybe in-person, virtual, hybrid models. I think depending on whatever state you're in for licensure and health insurance, I think because we have those barriers, right? So I definitely think that you'll see eating disorder programs offer in-person and virtual, more of a long-term treatment solution, because as we've all talked about, the access to care has just increased substantially over this past year. And, I know I want to continue to be able to service those areas that wouldn't be able to come into treatment, and those communities and those patients that can't drive the 4 hours into Boston as it would take back and forth. And I think that that's an important thing that has come out of the pandemic is access to care. And I think that we will see, I think the treatment landscape change a little bit. I think you'll see a lot of programs offer virtual and in-person treatment, or maybe a hybrid model, right? You'll have more hybrid program staff and more in-person staff. I definitely think you'll see the expansion of services that way.
I agree with that. I think that certainly I can speak for ERC. We're committed to both, obviously on-site care and committed to long-term virtual care at the IOP level. And we will continue to offer that with, dedicated virtual staff. And I see it and not as segregating in terms of different specialty groups or tracks, but really enhancement of the core. There's always the core issues of eating disorders that we're addressing, and then everyone has their unique features, and really trying to meet what we are seeing in terms of the community need and trying to provide that care. So we are addressing the commonalities while we're addressing the individualities as well. So I definitely see a very important role for virtual care from here on out. I think it's also, we've seen how technology can enhance care, and I think we're learning more and more about what telebehavioral health can do to enhance psychological care. And so I think that certainly we're committed to doing that and being able to offer both those services. So I think just like smartphones and social media changed the landscape of what we did way back when, I think this has forever changed it as well.
I don't think you can go back too, because patients and families have experienced what it's like too. And Kristen, your point about people driving 4 hours across Massachusetts to get there, right? They're gonna
they're not.
No, I'm not going to anymore.
Exactly.
It's not going to happen. I see the segregated treatment thing as like Deb, an and, not an or.
Yeah.
So it's sort of, there's sort of the core commonalities in the treatments that are universal and shared experiences and shared processes. And then there's the and so for some people it might be and a focus on gender, if that's particularly relevant for them, or and a focus on racism and experiences that have been impacting them and which then impact their eating disorder. And, you know, I can think of just general trauma experiences that might impact some people, that they could have, you know, that space as well. It's not an or, but an and. We have this opportunity to then make connections about these people with these extra shared pieces. I also am thinking about, you know, we're growing our programming into college, and where college students can have treatment that then goes home with them when they're back with their families, where usually you have to kind of pause or switch or something like that. And so the beauty of virtual that allows us to really have this fluidity as people move around and are switching. And I think that demand is just going to remain in place. It's not going away. To be honest, I also treated college students when I was in brick and mortar who would say, oh, it's so far away, you know, across campus.
Exactly.
and so I think, I think they're going to experience this and be like, can't I just like log in on my phone from wherever I am? And
they don't want to be
and so
going into the mental health building, right?
Right. The stigma piece is a great, the stigma piece is a great point of that, right? So if I can just do this at home, I don't even have to go into that like psychiatry building, where people might have thoughts about why I'm going there. And so, I think there's all these reasons why it's not going away. I'm glad brick and mortar places exist for people who need them. And I think there's a lot of benefits that are not changing.
We've all had some very, very common experience going into this with maybe a little trepidation, and then learning so much what our people, what they're teaching us, and what we can learn ourselves about changing up our programs. I mean, having been in the field for over 40 years, you get locked into, but this is how we do treatment. I know going back into a state where they'd only had inpatient and outpatient for 20 years and taking a PHP program into that, we just couldn't get people to send people. It was like, no, but if they're not outpatient, they need inpatient. And so you spend 10 years trying to teach people what a PHP is. Here we talk about cognitive rigidity and difficulty with set shifting with our patients. And yet then within the field, we are faced with, can we be open to looking at the needs of our patients and meeting our patients where they're at? And did we have to have a pandemic to force us to do this? Because I think it was in the makes, as you said, you inherited Equip, and it was ready to go in the virtual world instead of having to pivot like many of the rest of us had. But I'm left with this conversation feeling much more positive, actually, about what we're learning and what we're doing and how that's going to benefit so many people who struggle.
Similar to that point, Tamara, about PHP and having to sort of establish what is this and get sort of recognition for it. I think it's the same thing with virtual. And Deb, your point about insurance companies paying and everything like that, it's like, we've got to get everyone else to catch up and say, okay, this is legit and it's something that you can pay for. And I think we're started, and Equip has started to show that, okay, people will see this as you can do this, it works, and we'll pay for it. But now, as I think you both are describing and sort of moving forward in a hybrid of how, ensuring that insurance companies are going to pay for sort of the hybrid, right? What is this? Does it fit into a box? It doesn't fit into a box we're used to, right? So it's either like, okay, you're in person or you're virtual, and how can you incorporate both? And people, there's going to need to be flexibility around the payer side as well of what this programming really looks like and what it could look like and should look like, and really honoring what is possible there.
And telehealth has been around in some way, shape, or form for so many years. And I think it is unfortunate that it took a pandemic, I think, to catapult, where we're moving with telebehavioral health, exponentially. I don't think we would have gotten to this place as quickly. I think that, we know that insurance companies had a lot of doubts of it, but, now that the people, the masses have experienced it, that it can't, they're seeing it across the board in telemedicine as well as telebehavioral health. My hope is that, those advocacy groups with whom we all work can really help all of us advocate that we can make services accessible for people, and they do have a right to access to care.
Yeah, it's. I think that I did a webinar a couple of weeks ago on virtual programming, and we had over 400 people attend, and so people are still soaking up that information about what a virtual program looks like, and is it the same? Is it different? There's still all those questions out in the professional community that I think they're being answered every single day. Whenever we have a new outpatient provider refer to us, they're like, okay, so let's talk. What does virtual treatment look like? Is it the same? And we're like, yes, it's the same. It's, we really mirror our in-person program. And I think that's been the important message, is that the quality of our services has remained high, as they always have with Renfrew. And I think that's really important. And, I think that we were extremely lucky in the state of Massachusetts that our governor mandated insurance coverage for virtual treatment very early on in the pandemic. And that's one of the reasons why we were super quick to be able to shift into virtual programming. And I think there needs, like you said, there needs to be more just advocacy lobbyists at those levels with the insurance companies and down on Capitol Hill, and doing all that advocacy work so our patients can continue to get the care that they need even after the pandemic's over, because they're still going to need the care after the pandemic's over. It's not just going to go away, right? And I think that that's the important piece here, is that we need to be able to continue to provide this high quality care to those patients that, aren't going to want to drive or live in a remote area and can't drive. We still need to be able to provide access to care to those individuals. And I think that's really what has come out with the pandemic too, is that this isn't just a pandemic. It's touched on issues that have always been there. And I think that now those patients are, they're getting served with quality treatment.
Yeah. I think you've just identified a dissertation for someone, or
no, not me.
Someone that can collect all of the, kind of even so many things that we've touched on here today. A manual for providers. What do you do when your patient says, I don't like to see myself on camera? All the things that have come up in terms of the patient, and I can't tell if their knees going up and down. I can't. There's a lot of visual cues that I've always used that I have to change things up, and I have to look for different things. That doesn't mean that I'm losing something, but I'm going to have to change my vision in some way. So providers need that. I mean, I think patients themselves need to know and be taught how to get the most out of this form of treatment. And then we've got the whole, every state. We've extended in Colorado so that we can do virtual. Now we think, maybe we're going to get to the end of May, but what's going to happen in June? So every state making different decisions about the extent to which they will reimburse, or whether or not you're going to have to get separate license or join the psych pack or whatever's going to have to occur. One of you needs to get busy with this. Because you've all got great insight and experience with this, that I think we have to get it to our patients and to the providers and everyone within our field that is going through this.
I've loved doing this discussion with this panel with all of you.
Thank you.
I enjoyed it today a lot. I wish we could probably talk for hours more, right, about this.
So with that, I'm going to wrap it up. Thank all of you for your time and your expertise and just what you give. What you give every day to these patients who are struggling, and the families and loved ones. So thank you so much from myself and as a representative, NEDA.